Welcome to the Medical Center Hour. My name is Carolyn Engelhardt. I'm here representing Marcia Day Childress, and who is our usual moderator. She is out of town, and I am fortunate enough to be the lucky person to have the day after election Medical Center Hour. I'd like to welcome you all here. I'd like to give a special shout out to all my students and friends and colleagues who showed up. It's good to see everybody. The title of today's program is Morning in America. As you can see from your handout, that is taken from a 1984 Ronald Reagan reelection campaign where they introduced the theme Morning in America, promoting this image of the U.S. as a hopeful nation moving toward a better future. I'm sure many of you sitting in here today wonder just exactly what our future will look like after last night. And instead of me reading my little blurb to you, which you are very capable of reading yourself, I think that I will introduce you to our speakers so we can get the program going. We are very, very fortunate today to have two experts with us who can speak to national and state level healthcare policy. Delegate David Toscano represents Charlottesville and part of Albemarle County in the Virginia General Assembly. He is also the Democratic leader in the House of Delegates. There is no one who knows more in Richmond about this topic than David. I can tell you that for sure because he and I are friends and we have worked together for many years. Next to him is Professor Rick Mays from the University of Richmond. Rick has a long history. He's written extensively. He's worked in the federal government. He's an expert on Medicare. He'll talk a little bit today for all the docs in the room about how your Medicare payment will be changing in the future, as well as I've asked both gentlemen to do somewhat of a debrief on the election. It's been not even really 12 hours, so give us a little slack here when, as far as gazing into our crystal ball. Professor Mays will speak first, and then Delegate Toscano, and then we will open up for questions. I would like to also state that neither of our speakers have any financial interest to declare, and I know many of you are on call and on page. If you would just put your phones on vibrate or keep them close to you so we can have as few interruptions as possible. Thank you, and I'd like to present Professor Mays.
All right, thank you, Carolyn. Haven't had a day like this in a very long time. The last time I was this shocked about an election was when I used to work for George H.W. Bush, and we lost in 1992, and there was nobody I knew voted for Bill Clinton, and I didn't know anyone outside my circles who voted for Bill Clinton. And I think it's a great reminder to push ourselves outside of our normal comfort zones, our normal circles of engagement, read different sources of information, because nobody saw this coming. So in 20 minutes, I'm going to try to touch on both the ACA, its status now, where it's going. That's the first half. And the second half, I had to change a few slides this morning to make this work. But MACRA is another acronym that physicians especially are going to have to make their peace with in the coming years. It's not going to change based on this election. And so that's still worth talking about. So this is the surreal point of our politics. My former boss, by his own admission, voted for this woman to the right, who is married to the person who beat him, and she still lost. So if you can make sense of that, then you should be up here talking instead of me. How is the ACA doing for as much longer as it's going to exist? People love the insurance regulation reforms. They love getting rid of pre-existing condition exclusions, lifetime limits on health insurance, annual limits. They like more community rating. That stuff is very popular across the political spectrum. Republicans like that, Democrats like that. We have the lowest rate of uninsured population we've ever had since we've been recording. So in this sense, the ACA has done fairly well so far. Medicaid expansion, I'm going to leave the Delegate Toscano. Here we are down here, as you can see. We're in a different set of states that didn't expand Medicaid, so our rate of decrease doesn't match the states that have decreased. So we're okay in terms of our overall rate, but we could have been better. Is Virginia going to expand Medicaid now? I'll totally leave that to you. I wouldn't be hugely optimistic about that. That's the good stuff so far about the ACA. What has not gone as planned? There are still a lot of people that, even with the offer and subsidies and assistance, can't afford the premiums. And I think that's a big lesson that the nation has learned, is that we tried to thread the needle with Medicaid expansion for poor people and subsidies for people who are just above the poverty line to buy private insurance. And what we're finding is you have to be fairly far above that poverty line for the health insurance to be affordable. And then actually, once you get out of subsidy range, you're back into the situation where health insurance can be really expensive. We're also finding that for some of these policies to even be affordable, the networks of providers, clinicians and hospitals, has been very narrow, a lot more narrow than people thought. And that's also made the plan somewhat unpopular because you have insurance, but you can't see the people that you're familiar with. And maybe a lot of you have seen the increase in deductibles. I had a slide that showed how the average size of the deductible for a silver plan is $3,000 to $4,000 for an individual, and that's a lot of money to come up with before your insurance kicks in. For some family plans, it's $10,000. This is the news I think also really hurt Hillary Clinton, was the average increase this year in health insurance premiums, 21% based on the state you're in, a huge range. You can spend all day saying, well, it's not what it used to be, and it would have been higher without the ACA. It doesn't make any difference. That's a really high number. At the same time, the number of insurers in each county in the United States is going down. So those are the trends going in the opposite direction of what you want. Having said that, also some of the private insurers are pulling out of different markets, and I don't know if anybody here is losing sleep at night about how those poor health insurance companies are going to do. But you might think, oh my gosh, they're pulling out because they're losing money, the poor insurance companies. Don't feel bad for them. I can give you 20 other things to worry about before that. This is just their annual profits from last year. This is after everything has been paid, taxes, depreciation, payroll, everything. This is the amount of money health insurers made in pure take-home profit last year. And compared to the S&P 500 in the last 3 years, they've done great. In fact, this morning, they're the one sector that's jumped up the most. So don't worry too much about the health insurance. This slide doesn't work anymore. This slide was, Bill Clinton was saying, hey, there are some problems with the ACA, and this is how we could fix it. We could expand public option. We could let people 55 to 64 buy into Medicare. We could stiffen the penalties for people who don't have health insurance at the same time that we expand subsidies to help them afford that. I think all of this is a moot point at this point. You can tell by his face, he doesn't think there's anything more to this either. What are the prospects for bipartisan reform? All right, this slide is actually more relevant than when I made the presentation. I don't see hardly, the only area of agreement in surveys on health care between Republicans and Democrats and Trump, which is his own brand, is on pharmaceutical prices. That's the only area you see unanimity in that there's something has to be done. All the other things I showed you in the slide before, there's not consensus on that. So I don't think the prospects are very good for this. I think this slide maybe is the most important. We get fixated on a lot of the personal part. Is Hillary popular, unpopular? Is Trump offensive, and so forth? And those things people debate. I really think this is the slide that explains so much of our politics and why it's so hard for policies like the Affordable Care Act to succeed. And that's because I was born in 1969, so over these last 40 plus years, the middle class has really been hollowed out. It's much smaller than it used to be, and the poor of our society, the working poor and abject poor, have increased as proportion, and then what makes it even more complicated is the affluent have also increased. So it's really hard to have, the ACA is a targeted plan to help people who are uninsured primarily. That's its main objective. And to help people down here who are uninsured, most of the financing has to come from up here. And that's one reason why the plan has never been wildly successful, in contrast to things like Social Security and Medicare, because everybody pays into those, everybody benefits from those. And so Republicans like those programs, Democrats like those programs, but targeted programs are very vulnerable and susceptible, and they're not nearly as popular. Having said that, we've got to do something on health care, because if you look at how much Medicare and Medicaid takes up of the federal budget, it's the one thing in the future is really going to put a lot of pressure on our federal budget and take away spending on other things that we care about, like education and investments in roads and infrastructure and the environment. All right, I am a professor, so we have to have one equation slide. If you want to slow the rate of cost growth, as complicated as healthcare is, and I've spent my whole life trying to keep it in my head and explain it to students, and it is manifestly complicated. If you want to slow the rate of healthcare cost growth, there actually is, it's not that complicated. There's only 3 levers you can pull up or down. You can change the prices you pay for healthcare, and these are always broken out by public payers and private payers. You can change the volume of care, very tough to do. Other countries, this is what they do. They have queues to get hip replacements. They do X number of hip replacements each year, then you have to roll over to the next year. So that's how they control volume. We don't do that in the United States. And then the last thing you can do is you can just limit the number of people that you have access to the healthcare system. In the last couple of years, this has gone up. So these are the only things that you can do. And this is my old boss in the Bush administration, the UVA alum from 1979, Tom Scully. When I wrote my first book on Medicare, he had the most provocative quote that I led the book with because it was the most outrageous thing anybody had said to me in the interviews. It's not outrageous anymore, and actually I think a lot of people have come around to it. His whole argument was, and he ran CMS at the time, it's a fool's errand to try to get prices just right on all those CPT codes and DRGs for hospitals. You're always using 2-year-old data. It's a moving target you're trying to hit. You're always behind. The system is very easily gamed by different groups that have a stake in it. And his argument was, we should just get away from all of that, give every senior citizen a stipend to go out and buy private health insurance adjusted by their age and illness level, and then just walk away. And everybody was so aghast that he said that. I think this is the future of Medicare, and I think that's important because how Medicare goes and how it pays doctors and hospitals and providers is how the rest of the healthcare system goes. So, this is it. This is the next pivot to MACRA, which is the new payment system for Medicare for physicians starting in 2019. And if you aren't already depressed and overwhelmed, this is where the talk's going to take a darker turn. Because as polarized as Congress has been over the last few years, this is the one thing Republicans and Democrats agreed on, passed in 2015, to completely revamp the way Medicare pays physicians. And they're going to get rid of a lot of the traditional way of trying to get just every individual price right, and they're going to come up with a new system, I'm going to show it to you, about how to pay physicians, and then the whole rest of the private sector will follow suit. And you know the writing is on the wall for fee-for-service. When William Frist, a cardiac surgeon, Republican, former Senate Majority Leader, co-authors an article in the New England Journal of Medicine saying we've got to get away from fee-for-service. That's when everybody should know the days are numbered. The only reason why we haven't done it quicker is we just don't have the technical know-how to switch that quickly yet. And the real thing to notice is that it's going to start pushing a lot of the risk when you move away from fee-for-service to bundled payments and capitation. So a bundled payment is we're not going to pay 5 different providers for one hip replacement. The health system's going to get one bundled payment and they'll divvy it out to all the different anesthesiologists, diagnostic, the clinician. They'll parcel that out. It's not going to be 5 separate bills. That's going to put more pressure on the healthcare system to bring those costs under control. And then capitation is just full-blown. All the risk is shifted to the UVA or to any system that takes on that patient's care for the year. If you can bring the care in under the amount that you're given, you get to keep that or share the profit from that or to share the savings. If the care for that individual goes over, the health system's on the hook for that. What we're looking for is that sweet spot, how much risk to put onto providers and at what level. If you put too much risk onto individual physicians, it's bad for a lot of reasons we learned in the 1990s with managed care. So we're trying to figure out, do you want to put it at the health system, do you want to put it at a whole practice of physicians, or do you want to put it down on the individual level? We don't know yet what place is the sweet spot. Okay, so this is the thing that went through. Part of the Affordable Care Act was piloting and pioneering new ways of paying providers to reward them for quality and actually incentivize them to think more proactively upstream, do more prevention, do better care coordination, give clinicians more autonomy over the care and try to reduce their paperwork. And this is the terrible acronym we're going to get. Medicare is a new system. Medicare Access Child Health Plan Reauthorization Act. It's taken all these years of patching what we pay Medicare physicians each year because the old formula every year would have led to a decrease in what we pay physicians that was politically unacceptable. The problem is that every year that rolled over, and we were at the point where if we didn't do this and we just let the formula run out, it was going to be a 25% reduction in physician fees next year, and that was equally apocalyptic. So we have a new system. And you guys are going to have the physicians here are going to have either this model, or, this is, by the way, this is not in the legislation, the carrot, stick in the carrot. This is my interpretation of it. Physicians will either they can go with MIPS, merit-based incentive payment system, or they can find an alternative payment model, which I'll characterize for you in a second. You're going to have to choose one of these 2 options as a physician. And if you don't choose, it'll be chosen for you. This is the formula for determining the merit increases in physician pay from year to year. And I would go into the detail for this for you, but the regulations for it are already changing, so I won't do that. But these are all, this one stands out because this one already impacts physician reimbursement for Medicare, And the paperwork is so onerous on this that a lot of physicians don't even bother reporting it. They just take a 1% hit because it so detracts from the quality of their life, they don't even want to do it. So starting in 2019 under MIPS, if you're a high merit-based physician, your pay goes up 4%, but if for whatever reason your outcomes are deemed to be lower on merit, you can lose 4% on your reimbursement. When it's fully phased in 2022, if you're a high merit physician, you get a 9% increase. If you're a low merit physician, it goes down 9%. Just the fear of this and the fact that a lot of physicians can't control how the merit score will actually play out is pushing people. First of all, also, you got to go to the biggest practice you can get to. Because if you're a small practice, all the requirements to go along with this is going to make it very hard for you to actually come out ahead. So the carrot is to join a qualified plan, an alternative payment model, where we don't even know exactly, they haven't even released the exact details of what qualifies for this. I mean, we have passed legislation that hasn't even, the actual models have not been pilot tested, which is very different than DRGs in the 1980s. DRGs have been pilot tested in Connecticut and New Jersey, and William Michaud at Harvard did the same thing for physicians with the resource-based relative value scale. Those things have been pilot tested before they went into effect. These have not. This is still in play. And I think, in a sense, what is a qualified plan? It's as big a plan as you can be in that can take full risk for each patient, and that's how they're going to qualify. What is all this doing downstream to the healthcare system? What are the implications for healthcare in the United States? This trend's already happening. This change in Medicare reimbursement is driving this even faster to health systems getting as big as they can possibly get. And the small practices of 10 or less physicians are going to be a very hard thing to sustain in the future. So physicians are going to have two choices in my estimation. Join a really large health system or join the largest single specialty group they can find in their area. And in so doing, be so big that you have to have them in all the healthcare plans, and so big that they can handle all the risk. And just the example, if you ever spend much time in schools of public health or health administration like I have, you have to come to terms with this model, because this is like a religion. If you believe in Kaiser, you think the whole country should be Kaiser Permanente. Staff model, they own everything, it's vertically and horizontally integrated. They have the outpatient, they have the skilled nursing facilities, they have the pediatric clinics, they have inpatient trauma centers, they have everything under one roof. And so they can take a bundled payment or one sum and take care of all that patient's care. If you're enamored with this, and a lot of people are, this is the model, this is the future. The downside of this is monolithic, and this takes over whole regions, and it can drive out a lot of competition. The fear for a lot of physicians and health systems is you don't want to be down here in the future, right? And I used to work at Blockbuster in college, and I tried to tell students what it was like, and they looked at me like, why would you ever work at a kiosk? That makes no sense. And I always say it didn't used to be a kiosk, it used to be a place where you would go and with a date and say, let's go find a movie and walk around, and none of the films that you wanted to see were there, but that was half the point. Kodak, BlackBerry, Pan Am, these are all great companies that just couldn't adapt to the new models. And so these are the entities that have survived, and the same thing is happening to healthcare. An example is UPMC in Pittsburgh. This is the monolithic health system in Pittsburgh and all of Western Pennsylvania. They bought out every practice they need, and they're now selling their own health insurance. So if you're willing to buy it, and by the way, it's the cheapest in the area, because as long as you're willing to stay in the network of UPMC, they'll sell you the cheapest insurance there is. It's driving out all the United and Cignas and Aetnas, and there's not much insurance left, which means you have a monopoly left. There's not much competition. So right now, the cost of insurance is affordable, but once they dominate the whole market, we just have to ask them, please don't exploit that market share. And this is what's happening, and now this is going to be impacted dramatically by this election. The Obama administration was using the Justice Department to push back on antitrust, what they thought were antitrust violations. Health insurers and health systems getting too big in certain regions, hospitals buying out too many other hospitals for only one system left. I don't know if they're going to be that vigorous about antitrust enforcement moving forward. I doubt it. And in places like Boston, Partners runs the whole place until the Attorney General in Massachusetts said, no, you don't get to have all of Cape Cod, because every time you go into a region and we look at the prices after you've dominated, and before, the prices always go up. I'm from California. In many of these towns, it's Kaiser or Sutter, and that's all there is. And we're not that far from the Hampton Roads area where it's all Centera, and God bless Centera, but they're not satisfied just with the Hampton Roads area, as you all know in this town. It's like Lord of the Rings. They're moving across the valley, and they're buying up places like Martha Jefferson to expand their empire. And there's going to be like a battle between these large healthcare systems. And the last thing I want to comment, if I have time, I don't know exactly how this is going to play out, but once Medicare goes to full capitation or bundled payments and all these value-based programs, for the first time in all of healthcare, I think the paradigm is going to flip, and I think primary care physicians for the first time are going to get the upper hand on specialists. They've always been at the low end of the table because they've been outnumbered in all the annual updates, and the specialists have always outnumbered them. And in the system of volume-based care, the more RVUs you could generate as specialists, the more money you brought to the system, the more valuable you were. Under bubble payments and capitation, the whole thing flips, and if you are good at keeping people out of the hospital, keeping them healthy, avoiding readmissions, your stock's going to rise dramatically. And if you're a super subspecialist that doesn't do that kind of thing and that's not your forte, you now are going to cost the system a lot more. So I think we've talked about this for years. How do we incentivize and reward prevention and primary care? I think, and we've always thought, let the data do it, let people just do it for the right reason. Most people, at the end of the day, money's what changes behavior. And I think this shift in payment philosophy and just looking at the raw numbers at the end, I think this is when the nurses, the PAs, the primary care physicians, the people that keep people out of the healthcare system, that's Kaiser's secret, is keep people out of the hospital that shouldn't be in the hospital. That's how they make their money. I think that if you're going to finally see the primary care clinicians turn the tables on the specialists. Not that there's a competition, but when you've been kicked around for 30 years and you got small increases and you're always sort of marginalized, you can see what happened last night. You can only kick people around so long and not give them a fair shake. They're going to come back at some point. All right, how much time do I have left?
You've got 2.5 minutes.
All right, you guys want to do U.S. healthcare history since 1970 in one slide. DRGs was Medicare's first attempt to slow the rate of hospital cost growth. We were 5 years away from the trust funds from being expired. And that's a bundled payment for inpatient care, and it was a big deal, and it worked. But it worked in the sense that a lot of places just didn't actually lower their overall cost growth. They shifted increased costs to private payers to make up the difference for lower Medicare reimbursements. That worked to keep Medicare solvent, but they then shifted to the RVRVS for physicians that began in 1992 to slow the rate of Medicare cost growth for physicians, and that worked. In fact, those two worked so well that all those extra costs got shifted to private payers, and that gave rise to for-profit health insurers who came up with very restrictive, capitated, for-profit HMOs, managed care. That worked. That was popular for 5 years until they started kicking out moms after 24 hours, after C-sections, and they started rationing care in a very unpopular way. And we realized that eventually that didn't work, so we had to kick them out. And then over the last decade, costs kept going up, and we finally got the Affordable Care Act. And all of this is a response to the system trying to remain solvent. The healthcare system is built on about 7 to 9% increase in revenues every year. That's what providers need. That's what schools of higher education need, about 7 to 9% growth. And if you want to understand the history of U.S. healthcare, someone's not getting that 7 to 9%. And that becomes a crisis, and then you have to find a way to do it. Now, we've kind of squeezed all those places that you can squeeze, and now we need to put the we, meaning the government, feels like it has reached its limit of how it can manipulate prices. And it's not going to touch volume, and it's trying to increase the number of people covered. So the only thing left to do is to put all the risk back on the providers, which is going to make a very interesting decade to see how they can handle that. If you want to read more about this book just came out literally today. Brand new release by my colleague at Columbia, and she's got a whole book on the history of physician payment by Medicare for physicians. And I think the best medical writer on the scene, Atul Gawande, had an article called Overkill that explains this in more journalistic terms and easier to understand. Thank you very much.
Good afternoon. Good afternoon, everyone. Can you all hear me back there? Great. It's great to be here back at the university. It's great to hear the presentation of the professor. I'm just a small town country lawyer trying to do the best I can. Why do you laugh at that? That's pretty good. So I want to tell you a couple of stories, and then I'm going to put up some slides. I was joking about how I almost threw the whole slideshow presentation out the window this morning in aftermath of what happened last night. And I'm sure a lot of you stayed up late watching and trying to figure out what it all means. I'm the Democratic leader in the Virginia House of Delegates. And part of what I do is try to find good candidates for a run for public office and then try to operate their campaigns so they can win. So Hillary Clinton has been beset by health care from the very beginning. You remember when she worked with Bill Clinton to try to enact health care reform when he was president. And of course, she worked with Barack Obama. And I think that Obamacare sort of got her again last night. But it happens to me too. And I'll tell you a story how that happened. Back in 2013, we had a gubernatorial race, and we had a whole bunch of people running for the House of Delegates. A lot of problems in Washington, D.C., and a lot of our candidates were doing very, very well. And about 2 weeks out from the election, we had done a series of polls, and we were ahead in 6 of our contested delegate races in our polls. About 2 days later, what happens? But the unveiling of healthcare.gov, you remember the infamous website? That crashed and burned, and with it, so did our candidates. And we lost 6 of those races by a total of about 800 votes total. And if the election had gone on for another week or 10 days, Governor Terry McAuliffe would not be your governor. That's how serious it was. And with the recent increases in premiums, that kind of got to Hillary Clinton as well. So it's happened to me, it happened to her. It wasn't the only reason she lost, but it certainly was one reason. The other thing I might offer to you today is you're probably asking yourself the question, why is it that these stock values are increasing among pharmaceuticals and insurance companies? You would think that they would be going down, that there's so much uncertainty. But I would submit to you that maybe the good bet is that if Obamacare is repealed, then it's the market that takes over. And when that happens, you're not going to see insurance companies be constrained by the constraints and restraints of Obamacare. And the pharmaceuticals are probably not going to be restrained either. So they're making a bet. And so we're going to see how this all unfolds over time. I don't know what to say about Donald Trump and antitrust. I mean, anybody can guess what Donald Trump will do, because we really don't know very much what he will do in the federal arena to try to do something about health care costs. I mean, you just can't let the market run amok, or you're not going to be able to constrain costs. So you might see some antitrust stuff out of Trump. Who knows? He's so unpredictable. He doesn't fit very easily into the sort of conservative ideology that says let the market work. So it'll be interesting to see. Okay. I got a clicker. All right. So where do we go? I thought a timeline might be useful. You know, when Obama came into office, he had this idea that he would work together with Republicans to come up with some kind of health care insurance reform. And he said to himself, look, the idea of the individual mandate, the idea that everybody ought to be forced to play by buying insurance, is a Republican idea. And he said, oh boy, at least I got a Republican idea. I can use that to build a coalition of Democrats and Republicans to get something done. Well, the problem, of course, is he had Mitch McConnell in the Senate saying, our primary goal is to make sure that Obama doesn't get anything done throughout his term. And so, after a whole series of fits and starts, Obama realized that he could not get health reform passed using Republicans as part of the coalition. So like anybody who recognizes the words of Stevie Winwood in his great rock song, When You See a Chance, Take It, Obama said, this was my chance. I've got control of the House, I've got a majority in the Senate, and I almost have a filibuster-proof majority in the Senate, i.e. 60 votes. So I'm going to force it through, because that's my only chance to get it done. And, you know, the professor will tell us more about this, but when Ted Kennedy, a big proponent of health care reform, dies before Obama gets this passed, and Scott Brown, a Republican, takes his place, now Obama's got a problem. And the problem is that there are no longer 60 Democrats in the Senate, so he does the thing that any good president would do. He uses a procedural trick called reconciliation to get ACA passed. That occurred, and he signed the bill March 23rd, 2010. And we all know about a whole bunch of good things that have happened with ACA, and a lot of people like it. We also know there have been a bunch of challenges to the law, and now I'm going to use my handy clicker, and you can look at these and you can review these if you want. It's a lawyer's delight. Probably not something you guys are interested in, but for me, it was a lot of fun to read. A series of decisions that were made, one of which was very important for states, and that was this one here, where the Supreme Court upheld Obamacare, but said that we could not, the feds could not force states to expand Medicaid. Then it became an issue for states as to whether we want to expand. Couple other dates here. February 2, 2016, Republicans vote for the 62nd time to repeal ACA. Here's some data about insurance rates. And then we had some increases in the rates on the exchanges. Now, when January 1 or January 20 or January 21st rolls around, we're going to see what repeal and replace actually looks like, because nobody knows. They could repeal the law altogether, and that would throw everything into a total tizzy, because the health care system is very, very complex. And this law has been operating for a long period of time, and people have put together their whole lives based on this law. And if you just throw it out without something in its place, all hell breaks loose. Now, Donald Trump has a problem. Repeal and replace. First of all, with what? And secondly, can you even do it? Because Donald Trump has the House. He has a majority in the Senate, I think, unless I missed something late last night. But he doesn't have a filibuster-proof Senate. So he would have to play fast and loose with the procedures of the House and Senate to get anything through related to changing the health care law. That may be good, that may be bad. He can play with the budget, however, and there are all kinds of things that can be done. So we're going to find out what happens with that. Now, where are we now? We've got a lot more people insured than ever before, but in Virginia, we've got 1 million people on Medicaid. Now, you know the difference between Medicare. Medicare is the insurance policy for people like me who are of a certain age and can qualify. It's provisions for provide medical insurance. Medicaid is for really poor people and people who don't have as much money, who are old, disabled, people who have to be in nursing homes. It's an expensive program, and it's an expensive program for the state. In Virginia, we've got more insured than ever before, but we still have a big block of uninsured. Medicaid is partly funded by the state and partly funded by the feds. In Virginia, we put $1 in, the feds give us $1. It's a 50-50 split in the cost of Medicaid. If we had expanded Medicaid, we would have had 100% of that expansion paid for by the federal government, your tax dollars that are gone to Washington and sit in a pot till they're sent out to Connecticut or go wherever they are and not come back to Virginia. We wanted to get that money back, those of us who supported Medicaid expansion, and 100% of that expansion would be supported by the federal government. That, of course, drops over time to 97, 95, 90%, but it's still more than 50%, which is what we get back now from the federal government. Okay, who gets Medicaid? It's poor people, the elderly, working parents. The cost of Medicaid has been rising in Virginia. Virginia does a lot better than a lot of states, but we still have some pretty hefty costs, and that's what gets some people very worried. They say, you got to reform Medicaid first, and then you can consider expanding it. This shows you a pie chart of the difference in the budget drivers for the state budget over time. So you look over here and you see, where is it? Medicaid. 5.4% of the state general fund budget in 1985, 21% in 2016. That is a huge increase. That's what gives my Republican colleagues heartburn. And that's one of the reasons they don't like to think about expanding Medicaid. Of course, the irony of this is that they've been expanding Medicaid every year. Every year, they put another group of people in the pot. Usually they're folks that have severe disabilities. They're very costly to maintain. Last year, we put some folks that had mental challenges, mental health challenges, and we're putting them in at the least efficient way possible. We're expanding Medicaid in the traditional way. We're not expanding it in terms of getting 100% paid for by the feds. It's the most inefficient way possible. They don't seem to realize that. Okay, this shows that most Medicaid, the enrollment in Medicaid is mostly kids, but most of the cost is for long-term care. So unless you start kicking people out of nursing homes early, you're going to have a hard time on it. We rank 48th in Medicaid spending per capita, 48th. And these are some of the people. And we can go over those in detail later. But long and short is, my prognostication for whether the state will take on Medicaid expansion in this General Assembly session, I don't think that's very likely. Given what's happened with the federal election, I think it's highly unlikely that anybody in Virginia is going to be able to pass Medicaid expansion, even though it makes a lot of financial sense for Virginia. So I think I'm done.
Okay.
Right? And I want to open it up for questions. You know, you can tell us what you think about the election as well. So thank you very much.
Okay, great. Thank you both very much. We have a lot of time for questions, which is unusual in the medical center hour because we often don't. And I know that you have a lot of questions for our speakers. So,
and I got more slides too, if you ever want to see them.
I like threatened them with like an inch of their life so that we'd have plenty of time for questions. So, who would like to start?
We've got one right down here.
Okay.
So if Trump, 4 years down the road, has done things to the healthcare system, what will it look like?
Well, you know, it's all speculation right now because we really have never heard him say exactly what he means by replacing Obamacare. And so we don't have any idea what it's going to look like down there. I think it is fair to say one thing, and I think you'd agree with me, I hope you agree with me. It's not getting smaller. The healthcare system is only getting bigger. It's becoming greater part of our economy, greater and greater impact. And part of that is that we're getting older, and secondly, we're getting more demanding. And I think those two things are driving it. And you might have other comments other than...
I agree. He can't shrink the proportion of GDP that's consumed by healthcare. He doesn't have that power. And I think if you want some solace, he didn't, at the end, he jumped on the anti-Obamacare bandwagon because it sort of helped him. That wasn't his top 5 tirade throughout the campaign. He voiced support for Medicare throughout the campaign. There's loose talk that what he might do is the Republicans might repeal the individual mandate and subsidies, shift to tax credits to people to buy private health insurance, take Medicaid, shift it to a block grant to the states to let the states do what they want to do, which would not be good for Medicaid expansion. That makes it even harder. Because if you do that, it's a clever way to send less federal money to the states and put more of the financial burden on the states to pay for Medicaid. And then the question would be, with some of the states that expanded, would they then change their mind? Would any states then who are now in the 19 with us, would they switch? Not likely, not with financial burdens. So I don't think healthcare would look dramatically different, but some of the progress that's been achieved in the last 5 years would definitely be rolled back. And here's the one, if I could add one more thing. I always end that kind of comment to say, I hope that people in charge are still open to reason, right? If you find short-term ways to cut back on spending on healthcare, people who are still sick still fall through the cracks and they end up in places like this. The ER is the ultimate safety net in our country, for everything. And so if you don't pay for it up front, we are all going to pay for it in the emergency room. The cost will be shifted back out through private insurance, through dish payments from the federal government. It doesn't go away, it just gets diluted out and we all end up paying for it. So it'd be so much better to get people more access upstream. And you're in my class, you know this, right? You have a test, I think. It sounds like it's a political ploy, but the more people you get in the system and get them better access to primary care, but by primary care, doctors, specialists. Yes?
Okay, we have a question up here.
Yep, it's good for the country.
How can we increase the size of Medicaid in Virginia when we know that we're already into a deficit situation with the budget? And why not try to collaborate with the private sector as opposed to for solutions and management, as opposed to giving it over to the government, which we know makes a mess of everything they try to do?
Well, good question, and I hear that all the time, reasonable question. You know, first of all, Medicaid is not going away. There's no doubt it's not going away. There are a lot of people who you are friends with who need Medicaid because they can't afford to pay for nursing home care. Or they need Medicaid because their kids are too poor to access health care. And if they're too poor and they're very sick, they're going to need Medicaid. Or they need to go to an emergency room, like UVA, which is a quasi-government entity. So if you want to take the position the government ought never be involved in the healthcare system, then you're leaving everybody, your friends and neighbors, at total mercy of the marketplace and what their economic resources can provide to them. The thing about Medicaid expansion is that in Virginia, what was proposed was called Marketplace Virginia. And under that plan, the money would come in and insurance would be provided through the private sector. It wasn't government-run health care. It was a subsidy that was going to go to private insurance companies to provide the care. The only one who's really advocated for a government-run operation has been Bernie Sanders. Now, Donald Trump, interestingly enough, has taken the position, which I think is fascinating, that he has said, I want to provide health care for everyone in America. He said that on a number of occasions. We don't know what that means. It never really came up much in the campaign, but we're going to see what it means. Because if you repeal Obamacare and you replace it, you've got to replace it with something. And we don't know what that something is. Even if it's tax credits for everyone, do they have to use the tax credits to buy insurance? And if so, are they being forced by the federal government to buy insurance? So there are a whole...
we increase entitlements federally for the money you're suggesting would come from. We're up to $20 trillion in debt. It's not sustainable.
It's not sustainable. You're absolutely right. It is not sustainable without new revenues. It's not sustainable without new revenues, and I don't have the answer for you on that, but I can tell you that if Donald Trump wants to provide health care to everyone in America, he's going to have to find revenues to do it, because there ain't revenues out there right now to do it.
I also meant to ask each of you, when you ask a question, to please identify yourself. I had meant to say that before. So, another question?
We have one right here. Oh, okay. Hi, I'm Jordan. I graduated in May and I'm here doing research at the university. And so this is kind of similar to what we just asked, but more of a principal question. So the contrast so it seems we're either putting people into a public system or we're giving them money to go buy private insurance as an alternative to what we have. Is there any data that shows the efficiency of taking those people that are maybe in a federally subsidized program and putting them in the private system as far as driving down costs or quality of care? Is there any system like that that's already been done?
Generally speaking, private insurance has higher administrative costs. About 25% of premium dollars go to administration. Medicare, Medicaid, public options have lower administration costs. But there's even the argument that Medicare's, for instance, Medicare's administration costs are actually too low. In fact, you don't want it to be it's too efficient because they don't have enough personnel to catch waste, fraud, and abuse. So in between private and the public sector is a better ratio. That would be better for expanding coverage, but not being taken advantage of.
Yeah, I agree. There are some studies that show that Medicaid is a more efficiently run operation than private plans. And, you know, I mean, of course, you get the government involved in that, but...
One of the problems, I mean, hospitals love Medicaid, they don't love Medicaid. They love that any patients who otherwise don't have anything, if they have Medicaid, that helps their revenues. So the hospitals that you've seen in Virginia have been very pro Medicaid expansion. The doctors have sat on the sidelines for absolutely understandable reasons. I don't care how altruistic and humanitarian you are as a physician, you don't want to see your Medicaid payer mix increase because reimbursements don't match your costs. And the paperwork it literally kills a little bit of your soul every day. So that we haven't solved that yet. That's why physicians haven't been at the General Assembly anyway, like the hospital administration has. And I don't blame them. You can only ask clinicians. You don't want your policy to be everybody has to be a martyr. That's a terrible policy. So you have to increase the reimbursement rates or change the delivery system to make it worthwhile for their investment.
Did you want to ask a question?
Yes.
Okay. Would you pass that over, please? And please identify yourself.
Hello, my name is John. I'm a first year at the college here at UVA, and I have an interest in health law and healthcare reform. So my question, this may be more relevant to Delegate Toscano. So I guess given a world or a state of Virginia in which Democrats had control of both the House, the Senate, and the governor's seat, what steps would you and your colleagues be able to take to make sure that, given that discretionary Medicaid spending seems to be increasing and crowding out the budget in terms of education costs, which is, I guess, leading to higher costs in, say, higher education, for instance. Right, I think you had a slide up there that showed that.
So bring it up because you're on a roll.
Yeah. Well, given a state in which you had more power to do so, what steps would you take to make Medicaid expansion or Medicaid expenditures more efficient, or to make other non-discretionary costs more efficient so as to make, I guess, education better, for instance, or to make Medicaid still affordable to the state while tackling a possible budget or debt crisis?
Big question. All right. So first of all, let's take a look at this pot right now. This is the pot that exists right now. And certainly we've got to do something to get control of Medicaid spending. That is very difficult. The major ways you do that are what we would call coordination of benefits. There are some people who are dual eligible people. They are people who can take advantage of Medicare and Medicaid. If you can figure out a way to bring those together, you can cut some costs in reforming the system. And in fact, Virginia now has a process in place to create those savings. How much savings is going to be generated? It's hard to know, and how do you balance it out with those people who presently are in the system who are getting older, more infirm, and in greater need? Well, we got to get people out of nursing homes. There's no doubt about it. And one of the ways we can do that is change the incentives to provide more community care in non-nursing home settings. That might take some initial investment, but it will bend the curve a little bit. It's hard to say that you're ever going to be able to do much about this section. As to Medicaid expansion, however, that's funded not 50-50, that's funded 100% from the feds. So if we can bring that new people in who, and have the reforms in place, it's gonna help us. But is it gonna solve the problem? You know, we gotta grow the budget. There's no doubt about that. And that means creating more jobs, that means creating more tax revenues. No one wants to do a tax increase, and no one would support it for Medicaid expansion. But we're going to have to do more to bolster the economy so everybody can share in it.
Rick, do you want to respond to that at all?
I agree with that philosophically. I think we have a $1.5 billion shortfall, so expansion right now just seems politically impossible. And the gentleman who asked the question before, I don't think he's still here.
We drove them away.
Who drove him away. I think it's a legitimate point he raises, and I think it undercuts arguments for expansion, and I don't think Democrats and people who push for expansion take that question seriously enough. We do have annual budget deficits, we have accumulated deficits that are very significant, and we have interest payments to the Japanese and the Chinese every year that are 10% of our budget. And you can't just keep adding. You have to reform the delivery system. You got to find a way for the healthcare system to still survive but have lower overhead. And so just expansion on its own is irresponsible and not politically palatable.
I wish the gentleman had stayed, because I think that's the really critical point, is what do you do long term? Because this is not sustainable, and the federal government runs a budget deficit. We have to have a balanced budget. We right now have a shortfall in revenues, but it's not huge. It's going to be solved in Virginia. We don't have anything like what's happening in the federal government. But long term, you got to be worried about that number.
So I'm Guillermo Solosh, and I'm one of the physicians here. Question, and more of your opinion, realizing that at least as a clinician, a large, I don't know about the percentage, but so much goes into medications, and with the increasing amounts of costs to medications, I'm assuming that's driving a whole lot on the Medicaid and Medicare side. So just your opinion as far as what can the federal government do, and what do you, can you kind of comment on what may be done? Because otherwise, they're going to make a lot of money, and they still are making a lot of money. Right. And it's, at least from my perspective, my patients are going to suffer, budget's going to suffer, and it just puts a whole bunch of strain on the system.
I'll do a quick one. You can take over from there. In the last 2 years, pharmaceuticals are the single biggest increased component of healthcare cost increases. It's cyclical. There have been years where pharmaceuticals were negligible. In the last couple of years, they've jumped up, not for generics, but for brand new drugs that are very, very expensive. What could we do about that? There's other countries, other systems. You could benchmark the price to whatever the Veterans Administration pays, whatever Medicaid pays. Can you imagine the pharmaceutical company's response to that? Yeah, I mean, they would just go ballistic. And they have a lot of money, and they can lobby really hard. So it would make a lot of sense to do that, and that's what other countries do to limit the cost growth of pharmaceuticals. That's not been the American way. You could have Medicaid does that in many states. Medicaid benchmarks what it pays and buys at the lowest retail rate. Medicare chose not to do that. And so if Medicare didn't follow suit, it's hard to get that market leverage to do that system-wide. You could let imports in from Canada, but there's all kinds of powerful stakeholders that will push back on that as well. And the last option you have, my favorite, is Australia's. They just sit down in a room like this with all the pharmaceutical companies once a year, and they say, if you want entry to our $20 million market in every class of drugs, you got to give us a little bit. And if you get in, you'll make money off the volume. Per unit cost, you won't make that much, but you'll get 20 million people, and you'll make money, and they have some of the lowest pharmaceutical costs in the world. But that requires that the government actually do that. And they're cool with that culturally and politically in their country. We're not cool with that either. So I'm not optimistic on that. The only thing you can do right now is to shame them with journalism. And that's the only way you can, is to put them, haul them up before a committee and say, my God, what kind of human being are you to raise EpiPens to $600? But that's a terrible method. That's just drug by drug. And you need something much more systemic than that.
Yeah, in Virginia, we're doing some of that now. We have formularies in Medicaid that have to do with certain prescription medicines, and we're not going outside the formularies, otherwise you're not going to get the medicine. So, I mean, it is kind of a rationing thing, but it's the only way we can keep stuff under control. It'll be very interesting to see Donald Trump, because he is not beholden to anybody, including the drug companies. And whether he puts in a proposal to allow drugs to be purchased across state lines or through foreign companies, I think you better watch it, because that's like low-hanging fruit that's very politically popular. So watch that one, because that could be a pretty easy win for him right off the bat, because he's got the Republicans lined up on that.
They made themselves good villains, so that'd be a nice target to hit them really hard
That'd
first.
be interesting.
Okay, Scott.
I'm Scott Siverett, an emergency physician at the state hospital here. Just a very specific political question, which is, can Donald Trump use the same method that Obama used to get the Affordable Care Act through the Senate to repeal it?
Reconciliation. Yes, he can.
But I think it's a little bit more, I think it is a little more difficult now, because remember, they had passed it in the Senate first before it went to the House for reconciliation. And now the Senate knows that it's coming, so the Senate could filibuster the bill before it ever got to the House. But you could use reconciliation if you were in the right political posture to do it.
And you also got to be wary of some Republicans who are in very marginal seats might feel immense pressure to go along with that.
Right.
And one more thing, I recognize you from the remote area medical missions in Grundy. And I think it's the most amazing story. I've been seeing you there for years. I've been going down with my students. And every year, the weekend was horribly overrun. Patients came up, dental, vision, general medical, and they had to make a Sophie's choice about which one they're going to do. And then 3 years ago, we ended on Saturday afternoon. Everybody could get all the care they wanted, because all the people that came from West Virginia and Kentucky didn't come anymore because their states expanded Medicaid. And our patient population was purely Virginia.
Isn't it amazing?
So it was a great example of how public policy at that level can have that kind of dramatic impact.
So we have time for one last question, Meg.
Hi, my name is Meg Thornberry. I'm the health and science editor for the undergraduate paper here at the Cavalier Daily. A lot of women, and especially a lot of young women, are afraid that between promises to repeal the Affordable Care Act and promises to pass the First Amendment Defense Act or religious freedom bills, they're going to lose access to reproductive care. There's actually a campaign that right now that says, like, go out and get an IUD in the next 3 months because you won't be able to get anything afterwards. Is that a realistic fear?
I think it's very real in Virginia. Virginia, the House is controlled by Republicans, the Senate is controlled by the Republicans. You get a Republican governor and you bar the door. I mean, you'll see everything that Terry McAuliffe has vetoed get passed in Virginia. So next year's election will be a key election in Virginia as to what that looks like. Now, at the federal level, I'm not as conversant with some of the policy choices there. Maybe you have some insights about
I think it'll play out more at the state level. I think it is a serious threat. I would love to show the states that would consider that the example of Colorado, which has made IUDs and family planning much more accessible to women at low, no cost statewide, and they have the lowest teen pregnancy rate in the country. But that's data. This stuff touches on really emotional, philosophical, profoundly personal feelings that are not as susceptible to data. So I think it's a very legitimate concern, really legitimate.
You gotta engage in the political process.
Well, I think this is a good time for us to wrap up. Before we thank our speakers, I'd like to announce that the next Medical Center Hour will be Monday, November 28th. It's a special program on health information technology. What are the challenges? And the speaker is Dr. Vindal Washington from the Department of Health and Human Services. Please join me in thanking our speakers today.